Hey everyone, today we're going to talk about quality measures. This is going to be more of a higher level overview of a quality measure and its logic. This is not going to be a code walkthrough. If you're interested in seeing the code, you can take a look at the Tuba project GitHub, specifically at the quality measures data mart to see the code there. So we're going to talk about the measure. We're going to talk about a little bit about value sets related to that measure. We're going to walk through some of the logic. And then at the end, we're going to talk about some common data quality issues that may come up when you're running or calculating a quality measure for a patient population. So the example we're going to look through today is the breast cancer screening. So that has many different measure IDs, quality ID, it basically CQM 112 or in NQF 2372 or even the ECQM 125. So many different IDs. If you take a look at our knowledge base, we talk a little bit about the overlapping programs and different measure definitions that a quality measure may have. So the time frame for this measure is 27 months prior to the end of the performance period. A performance period is usually on a calendar year basis. So for example, if we were looking at 2023, our performance period start would be December 2023, and then we'd go back 27 months from there to find evidence for different criteria, part of that measure like exclusions and mammograms and things like that. So this measure is the percentage of women 50 to 74 years of age who had a mammogram to screen for breast cancer in the 27 months prior to the end of the measurement period. So the first step is gathering the value sets or the codes that are used in this measure. So if we hop over here and take a look at the measure itself, this is hosted by CMS. And this is the measure specification or the definition for that measure. And if we scroll down through here, you can see they do list codes. These are all the logic that we'll go through. They do list codes in this measure. And even at the bottom, if we take a look, you can see sometimes that's a lot of codes. This can be difficult to actually pull these codes out of this PDF. So an easier way to do this is to go to the Value Set Authority Center in the National Library of Medicine. You can enter a concept, or you can enter actually a measure ID. So in this case, this example is looking at ECQM version of this measure. And the value sets are organized by concepts. So acute inpatient, advanced illness, mastectomy, etc. We'll go through that a little more detail when we talk about the different logic and criteria. So this is kind of an overview of what we're going to be walking through today. And we'll look at each one of these sections in more detail. So the denominator logic. I'll say to start, for this example, we're going to walk through it's the Medicare. This was ran with the Medicare LDS 5% data set from 2020. So our starting population is 3.2 million, and our denominator eligible population was 521,000. So to get to that number, the denominator logic is patients aged 51 to 74 years of age at the beginning of the measurement period and had a patient encounter during the performance period. So the concepts or value sets that were involved in this logic is our demographics. So we have age, which is actually not a code. It's just a calculation based on their birth date. And then we have the sex or gender of the patient. And then we have our patient encounter concept. So this means, if it's a patient that was attributed to, a payer or an ACO, they have to have seen this patient during that performance period for this to count for them, for them to be required to actually do this screening, I guess is a better way to say it. And so there's various concepts on how to define that patient encounter. So it could be an office visit, telephone visit, just a normal wellness visit, etc. So for the numerator logic, it's a little more simple. We're just looking for mammography screenings, which could be bilateral screening or unilateral screening. And the denominator, again, was 521,000. And for numerator, or the mammograms we found in this population, was around 230,000. For the exclusions, these three exclusions listed here are what we found in this Medicare LDS population. There are other exclusions that we're going to go through on the next slide. So for frailty and advanced illness, We found 19,000. For hospice, we found 376. And then for mastectomies, we found almost 10,000. Again, that's out of the patient eligible population of 521,000. So to look more carefully at these exclusions, patients 66 years of age or older with an encounter for a frailty during the measurement period and either one acute inpatient encounter or two outpatient observation ED or non-acute inpatient encounters with a diagnosis of advanced illness during the measurement period or the year prior to the measurement period. Frailty can be a device, a diagnosis, encounter, or symptom. And again, these are all concepts that we have value sets for to help define these and find people that meet this criteria. Hospice service is used by a patient anytime during the measurement period. And then women who had a bilateral mastectomy or have a history of that, or where there's evidence that they had both a right and a left unilateral mastectomy. So the total exclusions we found here were 29,000. The deduplicated number is 28,000, and that's because a patient could qualify for more than one exclusion. So for the additional exclusions, we just didn't find these in the LDS population, and we'll talk a little bit more about that on the last slide because it could be due to common data quality problems. So these exclusions are patients 66 years of age or older with an encounter for frailty during the measurement period and a dispensed medication for dementia during the measurement period or the year prior. And again, frailty can be a device, diagnosis, encounter, or symptom. Patients age 66 or older in institutional special needs plan or residing in long-term care with place of service code 32, 33, 34, 54, or 56 for more than 90 consecutive days during the measurement period. And then finally, palliative care services used by patient anytime during the measurement period. So these weren't found, and that could be various reasons. So for the LDS data set, we don't have pharmacy claims data, so that may be why we don't have any medications for dementia. We don't know who is in a special needs plan, or this could also be related to, we need to create an encounter type for just residing in a long-term care. So long-term care more than 90 consecutive days, this may be made up of many claims. And so what we have to do is go through, find all those overlapping claims, group them together, and create an encounter type for that. So for example, in the TUBA project, we have some encounter types such as like acute inpatient stays. And so, we may need to build out a new encounter type to be able to find patients like this, or better be able to find these types of this criteria. So calculating the performance rate, this is bringing it all together. So the performance rate calculation is numerator divided by the denominator minus the exclusions. So again, our numerator, we found 230,000 mammograms, and this is divided by out of the 521,000 in our denominator minus the 28,000 exclusions we found, and that equals a rate of 0.4667 or 46.67%. So to kind of wrap up and talk about some of the common data quality issues, aggregating and deduplicating data sources, and tied to that is matching patients across those data sources. This can be really time-consuming and very complex work. A patient may have evidence of a screening in a different data source, but if you don't accurately match that patient, you're not going to find that screening. Missing data or not having enough data, so missing key data points required for the measure, missing types of data like labs or medications, or like pharmacy claims like we talked about. Some measures may go back several years for screening data, such as colorectal cancer screening, that you can look for evidence up to 10 years back for a screening, and you just may not have access to that much data. Some measures may require other data sources, such as labs or survey data. That's maybe not easy to obtain or to work with. And then lastly, like we talked about for those long-term stays, merging claims into encounters to accurately look for an institutional stay. Normalizing healthcare codes to the value set required by the measure. So you may be working with data from an EMR that maybe codes are documented as SNOMED, and the actual quality measure definition itself, those value sets may be ICD-10s and NDCs. And then finally, mapping custom data from an EMR. So again, like observations and report or document tags that we may be documenting mammograms as an observation or as a screening, and that has to be tied to an actual code so that it can be found when you run this calculation. So mapping those to a code from the value set can be difficult as well. So that's it. I hope this was a good introduction of quality measures and an overview of the breast cancer screening. Thanks for watching.